Have you ever felt like your energy just isn't quite what it used to be?
Mm-hmm.
Or maybe that drive, that kind of get up and go, well, it feels like it's gotten up and gone.
Yeah, that's a really common feeling people describe.
And it's so easy to just dismiss it, right? Just say,
Right.
oh, I'm just getting older.
Exactly. But what if there's actually a deeper story unfolding, something more specific going on inside your body?
That's what we're diving into today, the essentials of testosterone and really its profound impact on men's health.
And we're guided by some incredible insights from Nelson Vergel.
Absolutely. Nelson is a real authority here, over 30 years of experience in male hormonal health,
He founded ExcelMale.com, discountedlabs.com.
and wrote foundational books like Testosterone, A Man's Guide. So our mission today,
Well, we want to pull out the absolute core nuggets of wisdom from his work.
exactly, helping you understand the nuances of low testosterone, the risks, the tests, the treatments.
Think of this as your shortcut, maybe, to really grasping a topic that affects millions.
Yeah, a complex but really important one.
And Nelson's approach, it's rooted in decades of experience, both personal and professional. That makes his insights really valuable.
He's a research advocate, right?
Definitely.
Yeah.
But while we're distilling all this knowledge, it's so important for you, our listener, to remember. This is purely for educational purposes. Information.
Right. Not medical advice?
Absolutely not.
Hmm.
Any decisions about your lifestyle, about medication, about hormones, always make those in consultation with a qualified healthcare professional.
Our goal here is just to help you get informed, get empowered with knowledge.
Exactly. We're not writing prescriptions here.
Okay, let's get into it. Testosterone. So when you hear testosterone, your mind probably jumps straight to male hormone, doesn't it?
That's the immediate association for most people, yeah.
But Nelson Vergel makes a really key point. It's actually far more universal, more fundamental than just that.
While men definitely have a higher concentration, typically about 10 times more in the bloodstream than women.
10 times. Wow.
Yeah, roughly. But it's present and absolutely vital in both sexes.
And what's really remarkable, he points out, is its widespread impact. It hits numerous target organs all through the body.
Right, with effects that are common across both men and women. The main differences really only come down to the male-specific reproductive organs.
So what does that actually look like in terms of, its physiological reach?
Well, it plays a role in so many things. Think about hair growth patterns.
Including balding, right?
Including those patterns, yes. And it influences your skin's sebum production, that oiliness that can sometimes be linked to acne.
Okay.
In the liver, it's actively promoting protein synthesis. That's fundamental for building and repairing tissues.
And for male sexual organs.
Absolutely vital for development, for spermatogenesis, that's sperm production, and for the healthy growth and function of the prostate.
And upstairs, in the brain.
Direct impact. Libido, your overall sex drive, and mood regulation, too.
And muscles. That's a big one people think of.
For sure. It's key for increasing muscle volume and overall strength, that physical power.
But it doesn't stop there, does it?
Not at all. In the kidneys, it stimulates red blood cell production. Now, Nelson adds a little nuance here. He notes it's sometimes considered a slight misnomer. Testosterone doesn't directly stimulate the kidney itself,
Okay.
but rather signals the kidney to produce erythropoietin, which is a hormone that then stimulates red blood cell production.
So the end result is still more red blood cells.
Exactly. The effect is very real and important. Then in your bone marrow, it stimulates stem cells.
And the bones themselves.
Crucial. It accelerates linear growth and bone closure in growing kids, both boys and girls. And it's intrinsically linked to maintaining good bone density throughout life.
So yeah,
Yeah.
calling it just a male hormone really is a massive understatement.
Totally. It has systemic effects all over the body. And if we connect that to the bigger picture, it becomes really clear that a deficiency, low testosterone, isn't just about one little area.
Right, systemic.
It impacts your entire well-being. Nelson highlights several key effects that show up when levels drop below optimal.
Like sexual function. That's the one most people know.
That's commonly recognized, yes. A decrease in sexual desire, activity, maybe even dysfunction. But it's far from the only impact.
What else?
Beyond that, people often report this pervasive, decreased sense of well-being, coupled with increased irritation or just general moodiness.
Something just isn't right.
Exactly that feeling. And then on a deeper physiological level, low T can lead to decreased red blood cells.
Which could mean anemia.
Potentially causing anemia, yes, which shows up as fatigue, weakness. It also contributes to decreased bone mineral density.
Making bones more fragile.
Over time, yes, more susceptible to fractures. And your body composition takes a hit, too.
How so?
You see a decrease in lean body mass, muscle strength, usually accompanied by an unwelcome increase in fat mass.
Especially around the middle.
Often, yes.
Yeah.
And while so many of these symptoms just get brushed off as getting older,
Yeah, like it's inevitable.
Nelson Vergel stresses a really crucial point here. Normalizing testosterone blood levels can actually reverse most of these effects.
Reverse them. That's huge.
It is huge. That's where the profound implication for your quality of life really lies. It suggests many of these declines we associate with aging aren't inevitable at all.
There's symptoms.
Symptoms of a correctable hormonal imbalance that can significantly impact how you feel and function every single day.
Okay, so if it's so important, what exactly is low testosterone? You'd think there'd be a nice clean number right
You'd
now.
think. But here's where it gets, well, really interesting and honestly a bit frustrating.
Yeah.
Nelson Vergel explains that defining low T is actually a huge point of ongoing controversy. A big discussion in the medical community, even years after he first gave this lecture.
So no single answer.
Not really. The definition depends heavily on who you ask. Is it the European Academy of Urology, the International Society of Andrology, the Endocrine Society? They all have slightly different takes.
And the labs themselves.
Right. To add another layer of complexity, different lab companies, like LabCorp or Quest, have their own varying normal ranges
Based on their own data.
based on their internal databases of all the samples they run. So, amidst all this variability, what's the broad consensus?
Is there one?
Sort of. Generally, for total testosterone in men, the range is often cited as maybe 350 to 1,100 nanograms per deciliter.
Okay. And women.
Much lower. Typically 10 to 50 NGDL. But the disagreements on the low end for men are pretty stark.
Like what?
Well, European guidelines back in 2009 suggested anything under 350 NGDL total T or less than 65 picograms per milliliter for free T could be low.
Okay, 350.
But the Endocrine Society, they set their threshold lower, under 300 NGDL.
300. That's a difference.
It is. And then, maybe most revealingly, an expert panel in 2014, these were high prescribers, people really in the trenches. They considered anything under 400 NGDL to be low.
Wow. 400, so it's all over the place.
It really highlights the variation, and then you layer on the practical realities of the healthcare system.
Like insurance.
Exactly. Insurance companies often want you well under that 300, 350 mark, and you need clear symptoms before they'll even think about covering therapy.
But cash clinics are different.
Cash-based clinics operating outside insurance rules tend to be much more flexible. They might treat someone with levels up to 500 NGDL if the symptoms are really impacting their quality of life.
So that wide discrepancy really shows how much interpretation is involved.
Absolutely. It's not just about the number on the page, it's how it's interpreted in the context of the patient.
Which raises the question, how does age fit into this whole normal picture?
Right. Nelson outlines the natural decline, but, and this is important, with a crucial caveat.
Okay.
So testosterone levels typically do start to decline around 30 to 40 years old, roughly 1.2% loss per year.
So by 75.
By age 75, a man's total T is usually about 85% of what it was at 25. And the bioavailable T, the more active form, can be down to about 50%.
50%.
Yeah, but here's the critical point Nelson emphasizes. Many men in their 70s and 80s still maintain perfectly normal testosterone levels.
So it's not inevitable.
Exactly. It clearly shows that a decline isn't a mandatory part of aging for everyone. It's not a universal rule you just have to accept.
And what about the time of day? Does that matter for testing?
Hugely important. Understanding testosterone's circadian rhythm is vital for accurate testing.
It peaks in the morning, right?
It naturally peaks early in the morning, typically between 4 and 6 a.m. That pattern holds for both younger and older men.
But there's a difference.
The distinction is younger men tend to have higher overall levels and a much more pronounced higher peak during that time.
And older men.
Older men often show a kind of blunted peak. Their levels might be lower overall and more constant throughout the day.
Ah, okay, so that affects the normal ranges too.
Definitely. And it reinforces why those morning blood draws are absolutely crucial for an accurate assessment. Testing later can give you a really misleading picture.
So why does all this definition stuff matter beyond just how you feel? Does it link to actual health risks?
That's the critical connection Nelson makes. He dives into a series of studies linking specific testosterone levels to increased risks of various serious health issues.
Not just symptoms, but objective risks.
Exactly. And he notes the data is up on ExcelMale.com for anyone who wants to dig deeper. But here's the shocking part from Vergel's review of the data.
Yeah.
Even slightly low T, starting maybe around 450 ng/dL, begins to open the door to serious issues like metabolic syndrome.
Metabolic syndrome, that's the cluster, right? Belly fat, bad cholesterol.
Precisely. Increased fat mass, larger waist, low good HDL cholesterol, high triglycerides, all major markers for cardiovascular risk.
And as levels drop further,
The alarm bells ring louder. Below 400 ng/dL, studies have linked it to something called venous leakage.
what's that?
It's internal penile damage that can severely impact erectile function.
Okay. And below 350.
Below 350 ng/dL, studies show a worrying increased risk of all-cause death mortality from any cause, plus a higher risk of anemia.
Wow. All-cause death.
Yeah. But the real urgency, Nelson points out, often appears below 300 ng/dL.
That seems like a key number.
It really does. At that threshold, you're looking at a significantly higher likelihood of lower libido, frustrating weight gain, and a dramatically increased risk of developing type 2 diabetes.
Diabetes risk too.
And that same threshold, under 300, is also associated with an increased risk of fractures, noticeable memory issues, and a higher risk of depression.
It just keeps getting worse as it goes lower.
It does. Below 250 ng/dL, studies see increased arterial plaque contributing to heart disease and poor sleep quality.
Sleep quality too affects everything.
Below 235 ng/dL is specifically linked to hardening of the arteries, serious cardiovascular concern.
And erections.
For men noticing fewer morning erections, a level below 200 ng/dL is often a critical factor.
And the very bottom.
When T plummets below 150 ng/dL, there's a clear link to increased inflammation throughout the body. That sets the stage for all sorts of chronic conditions.
Okay, that's a lot of serious risks tied to these numbers.
And what's truly fascinating here is how these numbers seem to converge. Nelson Vergel points out that the 300-350 ng/dL range seems to be a kind of midpoint across much of this data.
Like a critical threshold.
Exactly. It suggests that the medical guidelines, even with all their debate, aren't actually that far off from what these studies indicate regarding increased health risks.
So it really underlines the broader implications.
It absolutely does. Testosterone deficiency isn't just about feeling tired or low libido. It points to systemic health issues, cardiovascular, metabolic, bone health, mental health.
Issues that could potentially be prevented or mitigated.
Precisely. By addressing the low testosterone, it makes it a critical area for your own awareness and definitely for clinical consideration. This isn't just about comfort. It's about long-term health outcomes and longevity.
Okay, let's get into the biological nuts and bolts here. Where does testosterone even come from?
Right. Nelson Vergel emphasizes a really foundational truth here. Cholesterol is the mother of all hormones.
Cholesterol, the stuff we worry about.
The very same. Without it, your body simply couldn't make any of your crucial sex hormones like testosterone, or even vital stress hormones like cortisol.
So it's the starting point.
It's the essential starting material. It kicks off this complex cascade, like a series of chemical steps,
Okay.
that ultimately leads to the production of various androgenic hormones, DHEA, androstenedione, and finally, testosterone itself.
But it doesn't stop there, right? Testosterone gets converted.
Exactly. It's not the final stop on this hormonal highway. It can then undergo a process called aromatization.
Aromatize, meaning.
Meaning an enzyme converts it into other forms of estrogen, specifically estradiol, estrone, and estriol.
So testosterone becomes estrogen.
Some of it does, yes. And while we'll talk more about estradiol later, based on Nelson's work, its production from testosterone is a key part of this initial pathway. It's crucial for understanding the whole hormonal picture.
It's all connected.
Very interconnected.
And how does the body control all this? It must have some kind of system.
Oh, absolutely. The body has an incredibly sophisticated feedback loop. Think of it like a highly sensitive thermostat for hormones.
Okay.
This is known as the hypothalamic pituitary testicular axis, or HPTA, and understanding this axis is absolutely critical if you want to comprehend how testosterone therapy works and what its implications are.
HPTA. Got it. So where does it start?
Think of your brain as the central control panel. The cascade begins in the hypothalamus, a small gland deep in the brain.
Okay.
The hypothalamus sends a signal, gonadotropin-releasing hormone, or GnRH, down to the pituitary gland.
Pituitary right at the base of the brain.
That small but mighty gland, yes. The pituitary responds by sending out two crucial signals, luteinizing hormone, LH, and follicle-stimulating hormone, FSH.
LH and FSH.
These travel through your bloodstream down to your testicles or ovaries in women.
And the testicles get the message.
They get the message. In men, they respond by producing both testosterone and sperm.
Okay, so that's the production line. Where's the feedback?
Right here. As testosterone levels in your bloodstream start to rise, this sophisticated mechanism signals back up to the hypothalamus and the pituitary,
Telling them
essentially, okay, levels are good, slow down production. It acts like a dimmer switch to maintain balance and prevent overproduction.
a negative feedback loop.
Precisely. Very elegant system.
So this raises a really important question. What happens when you introduce external testosterone, like with therapy?
Yes, and Nelson Vergel is crystal clear on this critical point.
Yeah.
When you inject testosterone or apply a gel, your body senses this external source.
A feedback loop kicks in.
Immediately, it sends a strong signal back to the pituitary and hypothalamus telling them to shut down your own natural testosterone production.
Shut it down completely.
Or significantly suppress it, yes. This means when you start TRT, you are primarily replacing your body's natural production, not just topping it up or supplementing it.
Replacing, not supplementing. That's a key distinction.
Huge distinction. And the consequence is significant. If you stop therapy,
Yeah.
that HPTA axis, your natural production line, can remain shut down or suppressed for weeks, maybe even months. And you'll likely just return to the baseline low levels that led you to treatment in the first place.
So it's a real commitment. You need to understand that going in.
Every patient needs to understand that up front. Absolutely.
Okay, so once testosterone is produced or replaced,
Yeah.
how does the body actually use it? How does it travel around? You mentioned it's not just one number.
Right. It's not as simple as just total testosterone. Nelson Vergel breaks it down into different fractions, and understanding these is crucial for knowing how it actually works in your body at a cellular level.
Okay, what are the fractions?
First, you have total testosterone. That's exactly what it sounds like, the sum of all the different forms circulating in your blood.
The overall amount.
Correct. Then, critically, you have free testosterone. This makes up only about 2% of your total T.
Only 2%. That seems tiny.
It is tiny, but it's incredibly powerful because this is the bioavailable form, meaning it's unbound to any protein, so it's readily usable by your body. This is the testosterone that can directly hop onto androgen receptors in your muscles, your brain, other tissues, and make things happen.
Okay, so free T is the active stuff. What else?
Next is albumin-bound testosterone. Albumin is a common protein in your blood. This testosterone is loosely bound to it.
Loosely bound.
Yeah, meaning it can be released and become bioavailable if your body needs it. Think of it as a kind of quick release reserve.
Got it. And the rest?
The rest, the vast majority, maybe around 98% or so, is sex hormone binding globulin, SHBG, bound testosterone.
SHBG, I've heard of that.
Right. This form is strongly bound to SHBG, and historically it was considered largely unavailable for immediate use by the body's tissues. Locked up, essentially.
But I sense a but.
There is a but. Here's a surprising fact, Nelson points out. SHBG isn't necessarily evil or just a binder that locks up testosterone.
Oh.
Newer studies are suggesting it has a more significant role. It might be involved in transporting hormones, maybe even acting on receptors itself throughout the body, influencing where and how hormones get used.
So it's more complex than just a storage unit.
Much more complex. It really emphasizes that nothing in the body's intricate hormonal system is truly evil. Even estrogen, which often gets a bad rap in men, has vital roles. Each component is part of a sophisticated balance.
Okay, speaking of SHBG, how does that change? You mentioned it binds most testosterone.
Right, and a truly intriguing aspect Nelson delves into is how SHBG levels respond, particularly as we age, and the resulting impact on that available free testosterone.
Yeah.
This SHBG level is often a point of obsession for some people online, constantly trying to lower it. But the reality, Nelson explains, is far more nuanced.
How so?
Well, as men age, SHBG does tend to naturally increase. And because it binds more testosterone, that can lead to a decrease in both free and total testosterone. It's a natural part of aging for many, but again, not universal.
Are there specific conditions that raise SHBG too?
Yes, beyond just aging. Things like liver cirrhosis, hyperthyroidism, and overactive thyroid, the use of certain anticonvulsant drugs, exposure to estrogens, and even HIV infection are associated with increased SHBG.
Okay. And what about the counterintuitive point you mentioned?
Ah, yes. This often confuses people. Nelson highlights that leaner individuals who consistently eat healthy diets often tend to have higher SHBG.
Higher, even though they're healthy.
Exactly, which confounds those obsessed with lowering SHBG at all costs. It suggests higher SHBG isn't automatically a marker of ill health, but can sometimes indicate a healthy metabolism.
Interesting. So what lowers SHBG?
Conversely, conditions often associated with decreased SHBG include obesity, certain kidney disorders, low thyroid function, hypothyroidism, the use of medications like glucocorticoids or progestins, anabolic steroid use,
Okay.
even acromegaly, which is excess growth hormone, and diabetes.
So this raises the question. Why would conditions that are generally unhealthy, like obesity or diabetes, lead to lower SHBG, potentially freeing up more testosterone? Seems backwards.
It does seem backwards, right? Nelson emphasizes that the body has these complex, often compensatory ways to try and modulate free testosterone. Simply trying to artificially force SHBG down isn't necessarily healthy or beneficial.
It could even be harmful.
Could be, depending on the underlying reason. The body's systems are intricately balanced. Messing with one part without understanding the whole picture can have unforeseen consequences in this delicate hormonal orchestra.
Okay, back to testosterone itself. You mentioned it gets converted not just to estrogen, but something else too.
Yes, testosterone doesn't just act as itself, it's also a precursor, a starting material for other powerful hormones. These conversions are often significantly misunderstood.
Leading to bad decisions.
Potentially, yes. Poor treatment decisions, confusion. Nelson highlights two key conversions. The first is to DHT, or dihydrotestosterone.
DHT. Heard of that one too. Often linked to hair loss.
Often linked to hair loss, yes. And acne for some. It's a very potent androgen converted from testosterone by an enzyme called 5-alpha reductase.
And it's important for...
It's linked to essential functions like libido, definitely, but also those potential negative side effects.
And the prostate. There's debate there, right?
Huge controversy around DHT's role in prostate enlargement, or BPH. Nelson notes that newer data suggests it might not be the primary culprit, especially at normal physiological levels. The data is still evolving.
How does DHT work?
It works directly and very powerfully on androgen receptors throughout the body.
And finasteride, the hair loss drug.
Right. Finasteride, brand names Propecia or Proscar, works by blocking that 5-alpha reductase enzyme, so it blocks the conversion of testosterone to DH2.
Used for hair loss or BPH.
Exactly. But Nelson also notes what he calls the finasteride syndrome, where unfortunately many men experience a dramatic decrease in libido from using it. It underscores DHT's powerful, sometimes unwanted effects.
Okay, so that's DHT. What's the other major conversion?
The second, and maybe even more misunderstood conversion, Nelson argues, is to estradiol. That's a form of estrogen.
Estrogen in men. Isn't that bad?
That's the common misconception. Nelson argues this is the most misunderstood hormone in males. He stresses very strongly it is not an evil hormone.
Really? What does it do?
In fact, estradiol in men is associated with numerous, absolutely crucial benefits.
Okay.
Increased bone density, for one, surprisingly, increased libido, decreased fat mass, improved cognitive function, clearer thinking, and improved lipid profiles, which is good for cardiovascular health.
Increased libido from estrogen. That sounds counterintuitive.
It does, but the data supports it. And conversely, if men have very low estradiol levels, they can experience symptoms strikingly similar to low testosterone itself. Debilitating low libido, brittle hair, cognitive issues like brain fog, and bone loss, increasing fracture risk.
Wow. So zero estrogen is bad too.
Absolutely.
Yeah.
Which is precisely why Nelson believes that aromatase inhibitors, drugs like anastrozole or tamoxifen, which block the conversion of testosterone to estradiol.
They lower estrogen.
Right. He believes they are significantly overused in the field,
leading to problems.
Leading many men to have, in his words, crushed estradiol levels, which comes with significant negative health implications. They mistakenly think they're optimizing things by getting rid of estrogen.
Throwing the baby out with the bathwater.
Exactly. A classic case.
So to kind of sum up testosterone's actions.
Yeah.
It works directly, but also through these conversions.
Precisely. Nelson highlights these crucial dual actions. First, it's androgenic actions, where it binds directly to androgen receptors, think muscle growth, libido.
Okay.
And second, it's anabolic actions. Many of these are actually mediated through that conversion, the aromatization, to estradiol.
So estradiol is key for the anabolic side.
It's vital for libido, for healthy body composition, for robust cardiovascular health. And interestingly, estradiol also serves as a critical feedback signal back to the HPTA axis.
The control system.
Right, telling it to reduce testosterone production when levels get high. It's a complex, beautifully integrated, and surprisingly collaborative system within your body. Now, before we even start talking about external therapy like TRT, Nelson Vergel places huge emphasis on lifestyle factors.
Things you can control yourself.
Exactly. Crucial, often overlooked factors that can profoundly influence your natural testosterone levels. This is about understanding what you can proactively do every day.
Like what? What's top of the list?
He firmly believes that sleep quality and hygiene are one of the main reasons for low testosterone, especially in younger men today.
Really? Sleep is that critical?
Absolutely. Disrupting your natural circadian rhythm directly messes with the production of melatonin and numerous other essential hormones.
Including testosterone.
Including testosterone, which is primarily produced during deep sleep cycles.
So what does he recommend for better sleep?
His recommendations are pretty comprehensive, but practical. Aim for at least 7 hours of quality sleep per night. Ensure your bedroom is as dark as possible, pitch black, ideally. And crucially, avoid electronics before bed.
The blue light issue.
Yes, especially after maybe 10:30 or 11 p.m. That blue light significantly interferes with melatonin production, telling your brain it's still daytime.
Consistency matters too, right?
Paramount. Try to go to bed and wake up at roughly the same time daily, even on weekends, to keep that rhythm steady.
Any other tips?
Staying well hydrated throughout the day helps. Engaging in relaxing activities before bed, reading a book, gentle stretching, meditation. Getting daylight exposure first thing in the morning helps set your clock.
And dinner.
Aim for a lighter dinner and not too late in the evening so digestion doesn't disrupt your sleep.
Okay, sleep is huge. What else?
Weight loss. This plays a truly significant role.
How much of an impact?
Being overweight can lower your testosterone by a substantial 100 to 250 nanograms per deciliter. That's a big drop.
Wow. And losing weight helps.
Absolutely. Conversely, even modest weight loss can lead to a measurable, meaningful increase in your testosterone levels.
What about blood sugar?
Glucose control is another critical factor. High glucose levels, insulin resistance, or full-blown diabetes can directly lead to lower testosterone.
And exercise helps with that.
Definitely. Regular exercise is a powerful tool to improve glucose control and overall metabolic health. It also helps with body composition, obviously.
But there's a catch with exercise, right? Overtraining.
Yes, a crucial caution from Nelson. Overtraining or overexercising, pushing your body relentlessly without enough recovery, can actually decrease testosterone levels.
So more isn't always better.
It's always about finding that optimal balance for you.
Okay. Sleep, weight, glucose, exercise.
Yeah.
Anything else?
Lastly, and this is challenging in our modern world, avoiding environmental toxins. These are often called endocrine disruptors.
Endocrine disruptors? Like what?
These ubiquitous pollutants and toxins are known to interfere with your hormonal system. They often increase estrogens and decrease testosterone in males. Things like certain flame retardants found in furniture and electronics, emissions from refineries, phytoestrogens compounds in plants like soy that mimic estrogen,
Okay.
hydrocarbons, a wide array of pesticides used in agriculture. They're everywhere.
So what can you realistically do?
Nelson offers specific, practical advice here. One easy step is to always avoid heating food in plastic containers.
Really?
Because plastics, especially when heated, can leach these disruptive chemicals right into your food, directly impacting your endocrine system. Making small, consistent changes like that can have a surprisingly profound impact over time.
Okay, so those are things you can do. But what about things you shouldn't do, like those T-booster supplements we see advertised everywhere?
Ah, yes, the quick fix promises. Nelson Vergel is absolutely unequivocal on this.
What's his take?
He states very clearly, there is no effective over-the-counter testosterone booster, period.
None, despite all the marketing.
Despite all the marketing, this industry is largely a multi-million-dollar venture where consumers seeking a quick fix are simply wasting their money.
That's a strong statement.
It is, but he points to the alarming truth. These products often face intense FDA scrutiny precisely because some have been caught containing undisclosed pharmaceutical ingredients.
Like what?
Like sildenafil, the active compound in Viagra.
Seriously?
In a supplement.
Seriously? Yeah. Which leads to a false sense of efficacy, right? The user thinks the booster is working, but it's actually an undeclared drug with potential side effects.
And the FDA.
The FDA frequently shuts down companies doing this, but the supplement industry overall is largely unregulated. There's no consistent requirement for quality control or independent ingredient testing before these things hit the shelves.
So buyer beware. What about just taking vitamins, like zinc or vitamin D? Don't those help T levels?
Nelson is clear on this too. Supplementing with vitamins like zinc, magnesium, vitamin E, K, D, B6, or folate only helps if you have a documented pre-existing deficiency in that specific nutrient.
Only if you're deficient. Only then. If your levels are already fine, confirmed by a blood test, taking extra won't boost your testosterone. You simply won't see improvements.
So save your money unless a doctor identifies a specific gap.
Exactly. It's about targeted correction of a known deficiency, not just randomly throwing supplements at the issue hoping for a boost. So this brings us to a really crucial point. Beyond just that general feeling of being off, what are the specific red flags for low testosterone that you should actually be aware of?
Yeah, what are the concrete signs?
Nelson Vergel categorizes them into two useful types: the more specific symptoms and the less specific ones. This gives a clearer picture of what to look for.
Okay, let's start with the more specific ones.
Right. These are things that can strongly indicate low T. Often they relate to sexual development or function.
Like,
for instance, in teenage boys or young men, it might show up as delayed sexual development, lack of pubic hair, maybe increased fat mass, just underdeveloped male characteristics.
okay, and an adult man.
Key indicators include a noticeably reduced sexual desire and activity. That's a big one. Also, a decrease in spontaneous erections, especially those morning erections.
That's often one of the first signs, right?
Often one of the earliest and most reliable symptoms people report, yes. Gynecomastia, male breast enlargement, can also be a sign, though Nelson notes it's pretty rare at truly normal testosterone levels.
What else?
You might see a noticeable loss of body hair, including pubic hair. The testicles themselves might appear very small or even seem to be shrinking over time. An inability to father children, obviously infertility. Height loss in young men, experiencing low trauma fractures, or being diagnosed with low bone mass density. Those are strong markers.
Any others?
Less commonly, but still possible with severe deficiency, are hot flashes and sweats in men. Symptoms we usually associate with menopause in women.
Hot flashes in men. Wow. Okay, those are the specific ones. What about the less specific symptoms?
Right. These are more general and could potentially be caused by lots of other things. But when experienced together, especially alongside some of the more specific signs, they paint a compelling picture.
Well, those sort of things.
A pervasive decrease in energy and motivation. Just feeling drained all the time. Feeling persistently sad or blue. Nelson notes the risk of depression increases significantly below that 300 ng-Del level.
There.
Poor concentration and memory disturbances, that classic brain fog people talk about.
Very common complaint.
Very. Individuals might experience increased sleepiness during the day, even after a full night's sleep. Anemia can be a factor, a noticeable reduction in muscle mass alongside an unwelcome increase in fat, leading to weight gain.
And performance.
Decreased physical work performance, just finding it harder to do the physical things you used to do easily, that can also be a symptom.
Okay, so many men immediately link low T with libido or erectile dysfunction. And this is a key factor, obviously.
Absolutely.
But Nelson Vergel makes a really critical point here. Testosterone is not a magic bullet for sexual health.
No, it's really not. Sexual desire and function are incredibly complex. They're influenced by a whole host of factors far beyond just your hormone levels.
Like what else?
Well, think about high levels of chronic stress. That can absolutely decimate libido.
For sure.
Certain common medications, some blood pressure drugs, antidepressants, even statins, are well known for potentially suppressing sexual desire and function. Other physiological issues can play a big role. High prolactin levels, maybe from one of those benign pituitary tumors we mentioned, organ failure, like advanced liver problems.
Lifestyle stuff, too.
Definitely. Excessive alcohol or recreational drug use severely impairs sexual function. The physical and emotional toll of major surgery or a chronic illness.
And underlying health condition.
Major contributors. Things like high cholesterol, heart disease, obesity, high blood pressure, diabetes, they all impact sexual function, often independently of testosterone. Even persistent sleep issues or physical injuries can take a toll.
And the psychological side.
Absolutely crucial. Your emotional connection, your attraction to your partner. Nelson notes this is often overlooked, but profoundly important for desire.
He says it sometimes amazes him just how many factors are involved in arousal and strong erections.
It's true. So while testosterone can absolutely improve libido for many men, often quite significantly, It's still just one crucial piece of a very intricate puzzle.
And he warns men can get really depressed if they expect TRT to be a magic cure-all.
Exactly. If they start therapy hoping it fixes everything, only to find other underlying issues are still impacting their sexual health, it can be very discouraging.
So it requires a comprehensive look.
A truly holistic picture, yes. Not just a single hormonal fix.
Okay, so we've covered the causes, the symptoms, the complexities. Let's shift gears and talk about the significant upside. What are the potential benefits of testosterone replacement therapy when it's genuinely needed and managed properly?
Right. Nelson Vergel highlights a really broad spectrum of improvements that can genuinely enhance a man's life, reaching far beyond just the physical changes.
What's top of the list?
One of the primary benefits often reported is improved cognitive function. Clearer thinking, better focus. That often goes hand in hand with a more positive overall mood, less irritability.
And libido.
Alongside that, men frequently experience increased libido and sexual stamina. That can be a profound improvement in quality of life and relationships.
And what about long-term health? Cardiovascular.
Yes, and here's where it gets really impactful. Nelson emphasizes improved cardiovascular health. He states a pretty stark fact.
Which is?
Believe it or not, men with low testosterone tend to die of heart disease faster than men with normal testosterone.
Oh, that's direct.
It is. And he openly acknowledges the past controversy around TRT and heart risk. Some older, often flawed studies did link higher doses or poorly managed therapy to increased risk.
But newer data.
Nelson argues that much more recent, robust data now indicates that normalizing testosterone levels in deficient men actually improves cardiovascular health.
How does he explain the older studies?
He points out those few earlier studies suggesting risk were often found to be poorly managed. For example, maybe they lacked proper patient monitoring or didn't include necessary interventions like phlebotomies to manage red blood cell counts, which we know can be a factor if not controlled.
Okay, so improved heart health. What else?
Significant improvements in body composition, specifically helping decrease that stubborn fat mass while increasing lean muscle. That helps boost metabolism too.
And blood sugar.
Often accompanied by improved glucose control. That makes TRT particularly beneficial for men who might be pre-diabetic or already have type 2 diabetes.
What about fertility? We talked about TRT suppressing it.
Right. While TRT generally suppresses natural production, Nelson points out fertility can be improved or maintained to a certain point with specific management strategies like using HCG alongside TRT. We'll touch on that more.
And physical performance.
Improved exercise functional capacity. Men often find they can perform better physically with more endurance and strength in daily life or workouts.
Any hints about longevity?
And finally, while the data set is still emerging, Nelson mentions some preliminary studies even suggest improved longevity and overall survival with optimized testosterone levels. It indicates a broad impact on health span.
Okay, lots of potential benefits. But how quickly do you see these things? If someone starts TRT, what's the timeline?
That's a really important question, and Nelson stresses it's hard to predict exactly. Everybody is different, he says. It depends heavily on your age, other health issues like diabetes or high blood pressure, your overall health status.
Right. But are there general timelines?
There are. He provides some general timelines that can give you a reasonable expectation.
Like inflammation?
A decrease in inflammation can often be seen relatively quickly. Typically within maybe 3 to 12 weeks of starting therapy as the body starts to normalize.
Blood sugar?
Improvements in blood sugar control take a bit longer. Anywhere from 12 to 52 weeks as your body composition and insulin sensitivity gradually improve.
And bone density. That sounds slow.
It's very slow. Building bone mineral density is a long process, requires significant time commitment. Bone remodeling just doesn't happen quickly.
Body composition, muscle gain, fat loss.
That can also take up to 52 weeks, a full year, to reach maximum benefits. Requires consistent effort and time.
What about mood? Depression?
Improvements in depressive mood can sometimes be seen surprisingly fast, maybe within 3 weeks. But for others, it might take up to 30 weeks for significant, sustained changes.
And just general quality of life, feeling better.
That can also see noticeable benefits within a few weeks. Nelson describes how men often feel really good in that first month, but then it might seem to plateau, which can sometimes be discouraging.
Yeah, I could see that.
But as a long-term user himself, he says, we wake up to the fact that it's actually improving our quality of life if they ever run out or stop therapy temporarily.
Yeah.
You realize the positive new normal you'd achieved.
Right. What about erections and ejaculation?
Notoriously difficult to assess, highly variable. Some men experience better morning erections, others don't see much change there. Depends so much on age and all those other factors we discussed.
But sexual interest, libido.
Ah. Now that, Nelson says, is probably the factor that improves the fastest and the most obvious.
How fast?
Typically within 3 to 6 weeks, it shows up as more interest in sex, a greater sense of attraction, just more of that fundamental flavor or drive that makes life feel more engaging.
And he emphasizes a point here.
Yes, a crucial one. If sexual interest does not significantly improve after a few months on TRT, something else is definitely going on that your doctor needs to investigate. It's usually one of the most reliable early indicators of TRT's efficacy.
Okay, so the benefits can be genuinely life-changing. But it's absolutely crucial we talk about the other side, too. TRT isn't without potential downsides, right? Especially if it's done poorly or not managed well.
Exactly. Nelson Vergel is very transparent about these risks. He wants patients to be fully informed and proactive.
So what are some common side effects?
One common one, particularly with higher doses or maybe certain delivery methods, is acne, oily skin, or folliculitis.
Folliculitis. Different from acne.
Nelson clarifies it's more of an immune response on the hair follicles, not just typical acne, though similar treatments often help.
Okay. What else?
Another potential change is a decrease in HDL cholesterol. That's the good cholesterol. It tends to go down a bit with higher testosterone doses.
And the big one. Red blood cells.
Yes. Perhaps the most common side effect, and one requiring vigilant monitoring, is an increase in red blood cells, measured as hematocrit.
Boy, is that a problem.
It can increase blood viscosity, basically, makes your blood thicker. Nelson states this often requires men to either donate blood regularly every few months to lower their count or adjust their TRT dose downwards.
And he thinks this is linked to the heart risk debate.
He believes this is a primary factor involved in that potential cardiovascular risk if it's not properly managed. Persistently thicker blood can strain the heart and increase clotting risk.
Got it. What about gynecomastia? Male breasts.
Gynecomastia, actual breast tissue enlargement, is really rare at normal, optimized testosterone levels, Nelson notes.
When does it usually happen?
Usually if the testosterone to estrogen ratio gets way out of balance or due to underlying genetics, maybe high IGF-1 levels. It's complex, not always directly tied to TRT itself.
And just sensitivity.
Right. He stresses that temporary nipple sensitivity or puffiness is not necessarily true gynecomastia. Men often freak out, assuming it's high estradiol, when it's often just a transient response.
Butter loss.
Increased male pattern balding can happen, especially for younger men who are already genetically predisposed. DHT might be a contributing factor there.
Sleep apnea.
TRT can potentially induce or worsen sleep apnea, particularly in men who already have it or are overweight. That really underscores the importance of screening for sleep apnea before starting therapy.
Okay. And the cardiovascular disease link again.
As we discussed, it's currently debated. Nelson highlights the newer studies showing improvement with normalizing T. He points to flaws in the few older studies that suggested increased risk, like poor management and lack of monitoring, especially for hematocrit.
Fertility. We know it reduces sperm production.
Definitely reduces sperm production and fertility. The HPTA axis shuts down, FSH goes towards 0, signaling no sperm production.
But men on TRT can still father children.
It doesn't mean they cannot, the rate is just reduced. But here's that significant development Nelson highlighted. As recently as 3 years ago from his lecture, doctors typically made men stop TRT entirely to try and father children, which was miserable for the patient.
Right, crashing their T levels.
Exactly. Now, ancillary therapies like HCG or clomiphene can often be combined with testosterone to help maintain sperm count without crashing T levels. It offers a much better path for fertility preservation if needed.
What about prostate issues? BPH, urinary symptoms.
Regarding benign prostatic hypertrophy, BPH, or urinary tract symptoms, the data is actually controversial. But Nelson points out most studies in the last couple of years before his talk actually show improvement in urinary symptoms with TRT, not worsening, which counters older fears.
Any other minor things?
Some men report anxiety when first starting TRT, but that tends to normalize later or with a dose reduction as their body adjusts. And water retention can sometimes increase in the first month or so, but usually normalizes after a few weeks.
So lots to be aware of and manage with your doctor.
Absolutely. Open communication is key.
Which leads to the question, even if someone has diagnosed low T and symptoms, are there people who absolutely should not get TRT contraindications?
Yes, absolutely. Nelson Vergel outlines clear contraindications to ensure patient safety. TRT is definitely not for everyone.
What's number one?
First is men with severe sleep apnea if it's not currently treated with a CPAP machine or another effective breathing device.
Why is untreated sleep apnea such a big deal? Nelson believes sleep apnea is one of the most common undiagnosed problems in men. And he notes it can occur regardless of body weight. Central sleep apnea affects leaner men, too.
Is there a sign to look for?
A key sign, he points out, is having a high red blood cell count, high hematocrit, even before starting TRT. That can indicate undiagnosed sleep apnea as the body overcompensates for low oxygen at night.
How do you diagnose it for sure?
The only way, he stresses, is through proper sleep studies, which are usually covered by insurance. It has to be ruled out or treated first.
Okay. What else is a definite no-go?
Another contraindication is a baseline hematocrit already greater than 50%. If your red cell count is high before TRT, therapy will only worsen it, increasing those risks of thick blood and cardiovascular issues.
What causes high hematocrit normally?
Common causes include prior anabolic steroid use, undiagnosed sleep apnea, again, being a smoker, having COPD, or a rare congenital condition called polycythemia. These need thorough investigation first.
And prostate health.
Yeah.
PSA levels.
For prostate health, a prostatic-specific antigen, PSA level equal to or greater than 4 ngml, is a significant red flag.
Why 4?
For doctors, providing TRT at this level carries medical liability. It typically requires a thorough workup by a urologist first to rule out underlying prostate cancer.
But there's nuance here too, right? About TRT causing cancer.
Yes, an important nuance. Newer data, cited by Dr. Cara in Houston, suggests TRT generally does not cause prostate cancer. There's a saturation model idea. Meaning once the prostate tissue is saturated with testosterone, adding more doesn't necessarily further stimulate cancer growth. It's a crucial distinction from causing it.
What about men with a history of prostate cancer?
If they've been successfully treated with a complete prostate removal, prostatectomy, and their PSA is normal or undetectable, Nelson says they don't necessarily have to be excluded from TRT.
But other treatments?
Those who've had radiation or other therapies might have different risks, requiring careful assessment by a urologist.
What about PSA increases on TRT?
That's important, too. If PSA increases by more than 1 ngml, especially within the first 6 months, that warrants immediate investigation.
Could be something else.
Nelson points out prostatitis, a simple prostate infection, can cause PSA to rise, especially if sexual activity increases. He advises trying antibiotics first before jumping to an invasive biopsy.
Okay. What about blood clots? History of DVT.
A prior history of clotting disorders like deep vein thrombosis, DVT, or pulmonary embolism is also listed as a contraindication, carrying an FDA warning due to relapse risk.
Is that common?
About 2% of men might have genetic mutations that predispose them to clotting disorders. While it's a highly controversial topic and many studies find no link between TRT and clots, it's a risk factor that absolutely must be discussed.
And finally, what about obesity or heart disease history? Are those contraindications?
No. And Nelson is explicit about this. Obesity or a history of cardiovascular disease are not contraindications, despite what some doctors might mistakenly believe.
Really? Why not?
In fact, he notes that obese patients often aromatize more testosterone to estradiol anyway, and they can potentially benefit significantly from TRT if it's managed correctly to improve metabolic health and body composition. It really highlights the need for nuanced, personalized patient assessment.
Okay, so if everything we've discussed today is resonating, and you suspect low T might be impacting your health, what's the very first step? How do you get a clear, accurate diagnosis?
Right. Nelson Vergel is very clear on this. A single blood test just isn't enough.
Why not?
He emphasizes that testosterone levels are naturally highly variable. They fluctuate throughout the day, even from day to day.
So one reading isn't reliable?
Not really. Therefore, his strong recommendation is always to run 2 morning time fasting tests to get a reliable baseline average.
2 tests, morning time, fasting. Got it. Why morning and fasting?
Timing is absolutely crucial. The blood draws should ideally be done before 8 or 9 a.m. That's when T levels are naturally highest.
And fasting.
on an empty stomach because eating, particularly carbohydrates, can cause a temporary insulin spike, which can actually impact and sometimes increase testosterone levels, potentially skewing your results low if you test later or high right after eating.
Okay. And what tests should be included in that initial panel?
Nelson recommends a really comprehensive initial blood panel. You want a full picture, not just the testosterone number.
Makes sense. What's on the list?
Obviously, total and free testosterone. You need both the overall circulating level and the bioavailable active form.
Right.
PSA, the prostate-specific antigen, to assess baseline prostate health.
Great.
LH, luteinizing hormone, and FSH, follicle-stimulating hormone. These are vital. They tell you how the pituitary gland and testicles are communicating, helping pinpoint the cause of the low T.
Finding the source. Good.
You'll also want lipids, a full cholesterol and triglyceride profile, a CMP, comprehensive metabolic panel, to check kidney and liver function, electrolytes, etc., and a CBC, complete blood count, to check red and white blood cells, hemoglobin, and, importantly, your starting hematocrit.
That covers a lot. Anything else crucial?
Yes. A point Nelson makes emphatically, and one often missed by doctors, is you must include sensitive estradiol.
Sensitive estradiol. Why sensitive?
It must be done using the sensitive assay or sensitive test method. Standard estradiol tests are designed for women's higher levels and are notoriously inaccurate for the lower levels typically found in men. Using the wrong test can lead to bad treatment decisions.
Okay. Sensitive estradiol. Got it. Last one.
Finally, prolactin might be checked, especially if the baseline testosterone comes back very low, say under 200 NGDL, or if other potential causes have been ruled out.
Why prolactin?
High prolactin, sometimes from a pituitary issue, can suppress testosterone, so it's another piece of the diagnostic puzzle.
So this comprehensive approach gives the best chance of an accurate diagnosis and understanding the root cause.
Exactly. It gives you and your doctor the best possible information to decide on the right path forward.
And understanding the cause. You mentioned LH and FSH help there. How does that break down? Primary versus secondary?
Right. What's fascinating is that low testosterone isn't just one thing. It has different root causes. Nelson explains two main types of hypogonadism, which reveal where the problem originates in that HPTA control system.
Okay, what's the first type?
The first is primary hypergonadism. Here, the cause is a problem directly at the testicular level.
The factory isn't working.
Exactly. Your testicles, the factory, aren't producing enough testosterone, even if they're getting the right signals from the brain's control panel.
How is that diagnosed on the tests?
The diagnosis for primary hypogonadism is characterized by high LH and FSH levels combined with low testosterone.
High LH and FSH, meaning the brain is yelling.
Precisely. The high LH and FSH show your pituitary gland is working overtime, signaling hard to the testicles, essentially shouting, "Produce more T!" But the testicles aren't responding effectively.
What causes primary hypogonadism?
Examples include genetic conditions like Klinefelter syndrome, which affects about 1 in 500 to 1,000 newborn males, or just general testicular failure due to injury, infection like mumps, or other damage.
Okay, that's primary. What's secondary?
The second type is secondary hypogonadism. In this case, the problem originates upstream, either at the hypothalamus or the pituitary gland in the brain.
So the control panel is the issue.
Exactly. The brain's control panel isn't sending enough signals down to the testicles telling them to produce testosterone.
And the diagnosis looks different.
Yes. Secondary hypogonadism involves low LH and FSH levels, along with the low testosterone. Here, the pituitary isn't signaling much, which explains why testosterone is low, even though the testicles themselves might be perfectly capable of producing it if they were stimulated correctly.
What causes secondary?
Examples include pituitary diseases, or those benign tumors we discussed, a condition called hemochromatosis, iron overload, high prolactin levels, the use of certain drugs like opioids, and chronic liver disease.
So different causes, but is the treatment usually the same?
Generally, yes. Both types are typically treated with testosterone replacement therapy, but finding the precise root cause is always beneficial for understanding the full picture and guiding long-term management.
You mentioned pituitary tumors. How common are those as a cause?
They're rare, but important to consider, especially if the low T is profound. Nelson explains that sometimes if levels are very low, maybe under 200 NGDL, and the doctor can't find another obvious reason after all those tests.
Yeah.
It's worth investigating for pituitary adenomas. These are often benign, non-cancerous tumors that can develop in the pituitary gland.
How are they found?
They can only be diagnosed definitively with an MRI scan of the brain.
And how do they affect hormones?
While many are benign and don't cause major issues, their presence can subtly disrupt normal hormone production. Some adenomas might produce excess prolactin. These are called prolactinoma.
High prolactin lowers T.
Exactly. Others might produce too much growth hormone, thyroid-stimulating hormone, or even excess FSH-LH. Prolactinomas, in particular, can significantly reduce testosterone by interfering with that delicate HPTA axis.
Can they be treated?
The good news is, if a prolactinoma is found, it can often be treated very effectively with medication. A prolactin blocker that helps bring prolactin levels down, often restoring normal testosterone production.
So surgery isn't always needed.
Usually not required unless the tumor is large and causing other symptoms, like vision problems from pressing on the optic nerves or persistent headaches. But it's a rare yet crucial differential diagnosis for those cases of unusually severe and unexplained low T.
Nelson Vergel, with, 30 years deep in this field, he's truly seen it all, hasn't he?
Oh, absolutely. The good, the bad, the ugly.
And he's distilled all those observations into this really powerful set of what he calls the top 10 mistakes men make when it comes to TRT.
Yeah, it's like a what not to do guide based on decades of experience.
Incredibly valuable insights, almost like a cheat sheet to help you, the listener, avoid common pitfalls and really optimize your journey. Nelson, what's maybe the biggest mistake you see, the one people should be most aware of?
Well, the first one, and honestly just a complete waste of money, is mistake number 1, spending any money on over-the-counter testosterone boosters.
We've covered that. Ineffective, often fraudulent.
Just don't do it. You're throwing money away. Secondly, men often make the mistake of giving up too soon on product choice.
Meaning?
If one form, say a gel, doesn't seem to work well for them, maybe they don't absorb it well, they mistakenly assume TRT itself isn't for them.
Instead of trying something else.
Instead of exploring the wide array of other effective options available, like injections or pellets, don't give up on TRT just because the first method wasn't ideal for you.
Okay. What's number 3?
The third, and Nelson says probably the most common mistake he observes, is wrong dosing.
Too high. Too low.
Often too low or just not optimized. Many clinics, even some traditional healthcare providers, unfortunately, don't diligently monitor men at that crucial week 6 or 8 mark to properly adjust the dose based on their individual blood work and symptom response.
Leading to frustration.
Leading to suboptimal outcomes where men are left on a prescription that isn't truly optimizing their levels, leaving them feeling like TRT isn't working when really the dose just wasn't right. Fourth, not knowing how to prevent or effectively manage side effects. This is absolutely essential for long-term success and feeling good on therapy. You have to be proactive.
Okay, number 5.
The fifth mistake, and a truly dangerous one, is the use of black market hormones. Underground labs, stuff bought online without a prescription.
Risky.
Extremely risky. These are unregulated products. You have no idea about the quality, the purity, the actual dose. It carries significant and unpredictable health risks. Just don't go there.
Wise advice. Sixth,
Nelson stresses inadequate communication with physicians. TRT needs to be highly customized. It's not a cookie-cutter approach where everyone gets the same dose or method.
So you need to talk to your doctor.
Your ability to clearly communicate your symptoms, how you're feeling, any concerns, your progress, it directly impacts the quality of care you receive more than you might realize. Be your own advocate.
Good point. Number 7.
Seventh, men often have unrealistic expectations. They go into TRT thinking it will miraculously cure every single issue they have: libido, erections, mood, energy, body composition, single-handedly, overnight.
It's a tool, not a magic wand.
Precisely. It's a powerful tool, but often works best as part of a broader approach addressing lifestyle and other factors too. Manage your expectations.
Okay, 8th.
Eighth, they forget about the effect of other hormones. Your body is interconnected. For example, your thyroid function is crucial for energy and metabolism. Nelson notes just checking TSH alone often isn't enough for a comprehensive thyroid assessment. You need the full picture.
Right, number 9.
Ninth, bad lifestyle choices. Things like excess alcohol consumption, chronic poor sleep, back to sleep, or a lack of consistent exercise can completely undermine the benefits of TRT. Even if the treatment itself is perfectly dosed and monitored, you have to do your part.
Makes sense. And the last one, number 10.
And finally, the 10th mistake, and Nelson says this is probably the hardest one to define, is not choosing the right doctor.
How do you find the right one?
It's tough. He suggests these truly informed, empathetic, and proactive doctors. The ones who really personalize care are often found through networking with other knowledgeable patients online. Places like his ExcelMale.com community can be invaluable for finding physicians who specialize in this kind of optimized care, which is sometimes lacking in more conventional settings.
Wow. That's a powerful list. And what's fascinating is how many of these mistakes really boil down to a lack of comprehensive understanding in that personalized care you mentioned.
Exactly. It truly underscores that TRT isn't a simple set it and forget it fix.
It's a journey.
It's a journey that demands informed patient engagement and skilled, attentive medical guidance. This is precisely why resources like Nelson's ExcelMale community are so vital. They help you navigate this complex landscape.
The common thread seems to be the need for the patient to be active.
Absolutely. An active participant in your own health, not just a passive recipient of a one-size-fits-all prescription. These commandments really empower you to be a more knowledgeable and effective advocate for your own well-being on TRT.
Okay, let's talk treatment options. But before we dive into the specific methods, Nelson makes an important point about regulation, doesn't he?
Yes, it's crucial context. Testosterone isn't something to take lightly. He reminds us it's classified as a Schedule III controlled substance by the U.S. Drug Enforcement Agency, DEA.
Schedule 3, like anabolic steroids.
Exactly, meaning it's highly regulated due to potential for abuse. Because of this, doctors need a special DEA license just to prescribe it, and the DEA keeps a pretty close eye on those prescriptions.
Does that affect prescribing?
It can. This level of scrutiny sometimes makes doctors, especially in more conservative settings, perhaps a bit more hesitant or conservative in their prescribing practices, even when a patient clearly meets the criteria and could benefit. It's just an administrative reality.
Okay, so bearing that in mind, what are the most common prescribed forms of TRT available today?
Gels and creams are currently the most prevalent in the U.S. They account for about 70% of prescriptions.
70%? Wow.
Yeah, they're often the first-line therapy doctors turn to, mainly because they seem easy to use.
What else is common?
Injectables are becoming increasingly popular. They offer a more direct, often more potent delivery, though obviously they might be seen as less practical for some people who really dislike needles.
Patches.
Patches, while once more common, aren't nearly as popular as they used to be. Issues with skin irritation, adhesion, less stable levels, they've kind of fallen out of favor.
The less common ones.
Then you have other less common forms, things like oral medications, which have liver concerns, pellets inserted under the skin, or nasal gels. Collectively, these make up a much smaller portion of the market, maybe around 3% or so.
So Nelson outlines the main FDA-approved options in the U.S. Can you run through those?
Sure. For gels and creams, common brands you'll hear are Testim, which is 1% strength, Fortesta, 2%, Axiron, which is uniquely applied to the armpit, and Androgel, available in 1% and 1.62% strengths. These are typically applied daily, usually after showering, absorbing through the skin.
Okay, injectable.
For injectables, the workhorses are testosterone cypionate and testosterone enanthate. Very effective, generally lower cost.
Any others?
There's a unique buccal option called Striant. It's a tablet that sticks to your gums, applied twice daily. Patches like Androderm still exist. For longer-term solutions, there are pellets, like the brand Testapel, which are tiny implants inserted under the skin every few months. A newer option is Natesto, a nasal gel applied twice daily inside the nostrils.
And long-acting injections.
Right. For long-acting injectables, there's Iziostid, which is testosterone enanthate in an easy-to-use auto-corrector pen, usually weekly. And then there's Avede, which is testosterone undecanoate. It's known overseas as Nebido and allows for much less frequent injections, typically every 10 weeks after the initial loading doses.
What about Sustain? Hear about that online sometimes.
Sustanon 250. It's a blend of 4 different testosterone esters, very common overseas, but it's actually not approved for use in the U.S.
Okay, that's a lot of options. Each must have its pros and cons.
Absolutely. And this is fascinating because each method of delivery has its own unique profile. This is exactly where that personalized care becomes so crucial. Your preference, your lifestyle, how your body responds, it all comes into play.
Let's start with the most common. Gels and creams. What are the advantages?
Their main advantages include a quick onset of action. You apply it, it starts absorbing. You get a more stable physiologic blood pattern because of the daily application, mimicking the body's natural rhythm somewhat, and obviously easy self-administration.
Any differences with compounded creams?
Compounded creams, often made by specialty pharmacies, are frequently not alcohol-based, which can reduce skin irritation compared to some commercial gels, and some compounded creams can even be formulated for application to the scrotum.
Why the scrotum?
That area has high 5-alpha reductase activity, so it can lead to potentially higher DHT conversion. Some men find this significantly improves their libido compared to other application sites.
Interesting. What are the downsides of gels and creams?
Several notable disadvantages. Insurance issues are common. Companies often have preferred brands, leading to high copays or denials for others. While rare, skin irritation can occur. But the most significant drawback, especially for gels applied to shoulders or arms,
Transference risk.
yes, the transference risk to women and children through skin-to-skin contact. It's absolutely crucial to avoid contact for hours after application, wash hands thoroughly, cover the application site, or use armpit-applied options like Axiron to minimize this risk. It's a major consideration.
Other downsides.
Some men experience unreliable absorption. Their blood levels just don't consistently get into that optimal range, say above 600 ng/dL, no matter how much gel they use. Minor complaints include a sticky feeling or some products having an odor.
How do you monitor levels with gels?
Nelson advises checking blood levels about 6 to 8 hours after application to see the peak effect.
Okay. What about injectables? Cypionate, Enamflate, Undicanote like Avede, pros.
Main advantages: generally inexpensive, especially the compounded versions. They're the oldest, most established treatment method, and they are highly effective at raising testosterone levels, reliably getting men into optimal ranges.
And the long-acting one? Avede.
Long-acting Avede offers the benefit of more stable levels compared to less frequent standard injections, and obviously much less frequent injections every 10 weeks after loading doses. That's very convenient. And compounded testosterone cypionate, usually 200 mg/ml, is a very common, cost-effective option, often shipped right to your home with supplies.
Cons of injections.
The primary disadvantage, especially with less frequent injections like every 2 weeks, are those noticeable peaks and valleys in blood levels.
Roller coaster effect.
Exactly. Levels spike high right after the shot, then slowly decline, potentially leading to fluctuations in mood, energy, side effects. There's also generally a higher risk of increased red blood cell production, hematocrit compared to gels, requiring diligent monitoring.
Any issues with Avede specifically?
Avede requires a large injection volume, so it has to be administered by a doctor or nurse in clinic. And Nelson mentions that unique, though usually temporary, side effect for Avede, a post-injection cough that can happen right after the shot for some people.
Okay. Pellets, testopple compounded ones, advantages.
Pellets offer distinct advantages. They provide a long duration of effect, typically 3-4 months, excellent stability in testosterone levels once they settle in, a good overall safety profile, and significantly better compliance. You don't have to remember daily gels or weekly shots. Set it and forget it mostly.
But they require a procedure, right? Disadvantages.
Yes, they require a minor surgical procedure for insertion. Done in office, under local anesthetic, usually tiny implants placed under the skin in the upper glutes. There's a risk of pellet extrusion, where the pellets basically pop out of the skin. Nelson says this happens in about 10% of patients, often if the insertion wasn't done quite right or there's too much pressure on the site afterwards. Bruising and infection can also occur, though rare, typically related to insertion technique or patient factors like being on blood thinners.
Does it hurt? Can you feel them?
Nelson recounts his own experience getting pellets, saying the insertion wasn't painful at all. And once they're in and healed, you generally don't feel them under the skin as they slowly dissolve over those months.
How are they monitored?
Monitoring involves measuring T levels right before the next scheduled insertion to see if the timing is right or if you might need insertions slightly more or less frequently.
Okay. And briefly, patches and nasal gels. Downsides.
Patches like androgen have really fallen out of favor. Issues with skin irritation are common, levels can be less stable, and they're just less convenient for many. Nasal gels like Natesto are applied twice daily, but downsides include potential headaches from the rapid T increase, sinus congestion, and local nasal irritation.
Got it. You mentioned compounded options. Nelson has a distinction about the type of compounding pharmacy.
Yes, a critical distinction, especially now, for quality and safety. He explains there are 2 main types regulated by the FDA. 503A compounding pharmacies are typically smaller, traditional pharmacies, often local, that compound based on individual patient prescriptions.
Our 503.
Then there are 503B outsourcing facilities. These are much larger operations. Crucially, they are held to the same strict quality and sterility requirements as major pharmaceutical manufacturers, especially for things like injectable medications. This requires huge investment in equipment, testing, and processes, ensuring a higher, more consistent standard of production.
And this matters because
Nelson points out that due to these stringent new regulations, many smaller 503A pharmacies can no longer legally produce sterile injectables. It significantly changed the industry landscape, pushing sterile compounding towards these larger 503B facilities.
what are the general benefits of using compounding pharmacies, though?
Potential benefits include being cheaper than commercial brand names. They can often offer higher concentrations, like in pellets or creams, and sometimes they can provide specific formulations not commercially available, like certain testosterone creams tailored specifically for women's needs, which Nelson also discusses in other work.
Okay, let's talk dosing, especially for injections. It's not one size fits all. Nelson explains how frequency and the type of ester matter hugely. What exactly is an ester?
Right. Pure, raw testosterone, if you just injected that, has an incredibly short half-life, maybe only 10 minutes. Your liver would just dispose of it almost immediately.
Useless for therapy.
Totally useless. So chemists cleverly attach these things called esters, which are basically small molecules onto the testosterone molecule itself, usually at a specific position like number 17.
What does the ester do?
It acts like a time-release mechanism. It prolongs the testosterone's half-life, allowing the body to cleave it off slowly and utilize the testosterone over a much longer period. This is why you hear names like cypionate, enanthate, propionate, undecanoate. Those are the different esters attached.
And different esters last different lengths of time.
Exactly. Each ester determines the duration of action. Propionate, for instance, is shorter acting, so it requires more frequent injections, like every other day or even daily for super stable levels, to maintain consistency.
Yeah.
Cypionate and enanthate are medium acting, lasting longer than propionate. These are the most commonly used esters in the U.S. for weekly or twice-weekly injections. Undecanoate, found in Avit-Nebido, is the longest acting, designed to provide stable levels for anywhere from 8 to 12 weeks between injections.
So the ester choice affects the injection schedule. Nelson also talked about how dosing strategies have evolved.
Yes, hugely. He details the evolution, showing how medical practice has improved over time for patient benefit.
What was the old school way?
The old school method, common maybe 30, 40 years ago, typically involved injecting a large dose, say 200 milligrams, only every 2 weeks, usually done intramuscularly, IM, deep into the glutes.
What's wrong with that? Fewer shots sounds good.
The problem, as blood level graphs clearly show, is it leads to massive peaks and valleys. Your testosterone, your DHT, your estradiol, they all spike really high right after the injection, giving potential side effects. Then they crash down considerably by day 14, leaving you feeling low again.
Creates that roller coaster effect.
Exactly. Bad for mood, energy, side effects, overall well-being.
What's the new school approach?
The new school approach, which Nelson strongly advocates and is increasingly popular, involves administering smaller, more frequent doses.
Like how frequent?
Like maybe 150 milligram total spread over the week, perhaps injected once a week or even better, splitting that dose into twice-a-week injections, say 50, 75 milligrams each time.
What are the benefits of more frequent, smaller doses?
The benefits are really clear. It dramatically minimizes those peaks and valleys. It leads to significantly more stable blood levels throughout the week, which means better, more consistent efficacy, a lower risk of high hematocrit, less red blood cell overstimulation, and fewer overall side effects. Much smoother experience for the patient.
Some people inject even more often.
Nelson even highlights the extreme dedication seen among some guys on ExcelMale who might inject a short ester like propionate every single day to achieve incredibly stable levels. That shows real commitment to consistency.
What does Nelson do himself?
He shares his own routine as an example.
Yeah.
He injects himself with 75 milligrams twice a week using a tiny insulin syringe. He finds that very effective and easy for maintaining stable levels.
Okay, for people considering injections, that idea of a big, scary needle might be a real turnoff. But Nelson Vergel describes how techniques have really been revolutionized, right? Making it much easier and less painful.
Absolutely. The old image of TRT injections is often outdated. The old school intramuscular or IM method did used to involve longer, larger needles.
Like how big?
Maybe a 1.5-inch 23-gauge needle, typically injected deep into the glutes or the quads.
And you needed 2 needles.
Often, yes. You'd use a larger 18-gauge needle just to draw the thick, oil-based testosterone out of the vial and into the syringe. Then you'd have to swap that out for the smaller 23-gauge needle for the actual injection.
Why swap?
Because needles get slightly dulled just piercing the rubber stopper on the vial. Swapping ensured a sharper needle for injection. Plus, you had to perform aspiration.
Pulling back the plunger.
Right. Pulling back slightly to make sure you hadn't accidentally hit a blood vessel before injecting. It added a layer of anxiety and complexity. Nelson admits, while maybe less painful than people feared, it was still something you were not looking forward to.
But newer techniques have changed all that.
Completely changed the game. The newer techniques utilize tiny insulin syringes.
Like diabetics use.
Exactly. These have much smaller, shorter needles, typically 27 gauge or even finer, and only about half an inch long.
What are the advantages?
Numerous advantages. They are significantly less painful, obviously. There's no need for a separate loading needle, which also means less wasted testosterone left in the needle hub and fewer supplies needed overall. They provide good penetration for the intended methods. And crucially,
No aspiration.
no aspiration is needed with these shallow injections. The chance of hitting a significant vein or artery with such a small, short needle going in shallowly is extremely low. It makes the process much safer and simpler for self-administration at home.
What are the main methods using these small needles?
The modern methods include subcutaneous sub-Q injections. This means injecting just under the skin, typically into the abdominal fat or sometimes the gluteal fat pads.
Is sub-Q effective?
It's widely used. Nelson does reference one study in transgender female-to-male patients that showed, in that specific group, maybe not really good blood levels consistently with sub-Q compared to IM. However, countless individuals report using sub-Q very effectively. It likely depends on individual factors.
This is the other main method.
The other highly preferred and effective method, particularly favored by Nelson himself, is shallow intramuscular, shallow IM.
Shallow IM, how's that different?
You use the same small insulin syringe, but instead of pinching fat, you inject into muscles like the deltoids, shoulders, or the quads, thighs. It goes just deep enough to get into the muscle tissue, but nowhere near as deep as traditional IM.
Why does Nelson prefer shallow IM?
He personally finds he gets less redness or local irritation compared to sub-Q in the abdomen, but both are vastly easier and less painful than old-school deep IM.
Any cautions with these small volume injections?
Yes. Nelson offers a practical tip. Don't inject more than about 0.5 cc or half a milliliter with an insulin syringe in any single spot. Injecting larger volumes repeatedly in the same small area could potentially lead to scar tissue buildup over time, which might interfere with absorption. Better to split larger doses or rotate sites.
And injection sites. Where can you do these shallow injections?
You have lots of convenient options. Deltoids, glutes, upper outer quadrant, upper outer thigh, and the abdomen for sub-Q. The key takeaway is that injections have become far more patient-friendly and accessible, removing a huge barrier for many men.
Okay, so injections are much easier now. What about pellets? If injections really aren't for someone, pellets offer that set-it-and-forget-it approach, but they involve a procedure. What's that like?
Right. Pellets are an intriguing alternative, but yes, they do involve a minor in-office procedure. Nelson describes what it typically entails.
Where is that at?
Usually performed in a discrete area, like the upper outer quadrant of the glutes. The area is numbed first with a local anesthetic, like lidocaine.
So you don't feel it?
You shouldn't feel pain. Then, a very small incision is made, just a few millimeters long.
And the pellets go in. How?
The pellets themselves are tiny. They look like little grains of rice. They are then inserted just under the skin using either a specialized instrument called a trocar, which has a sharp pointed end to create a small tunnel for the pellets, or sometimes just with sterile forceps.
Sounds straightforward.
It usually is. Nelson recounts his own experience getting pellets, saying the insertion itself wasn't painful at all. And once they're in and the small incision heals, usually just needs a steri strip or a single stitch, you generally don't feel them under the skin. They just sit there and slowly dissolve over the next 3 to 4 months, releasing a steady, consistent dose of testosterone.
Are there potential complications, though?
While generally low risk, there are a few potential complications to be aware of. Pellet extrusion is the main one Nelson mentions.
Pop it out.
Yeah, where the pellets basically work their way out of the small incision site before they fully dissolve. He says this happens in about 10% of patients. It's often related to the insertion technique, maybe placed too superficially, or if there's excessive pressure or movement on the site soon after insertion.
Anything else?
Bruising and infection can also occur, like with any minor procedure involving an incision. These are typically related to the insertion technique as well, or sometimes patient factors, like if someone is on blood thinners, which increases bruising risk.
Nelson showed a picture.
Yeah, during his lecture, he showed a visual comparison. A picture of a nicely healed pellet site versus one that got significantly bruised, just to illustrate the difference in outcomes. But overall, when done well, pellets remain a highly effective, safe, and very convenient long-term TRT option for many men. So once you're actually on TRT, the journey isn't over. In many ways, it's just beginning. Proper, consistent monitoring is absolutely key.
Key for what?
For optimizing the treatment, getting the dose just right for you, and for effectively managing any potential side effects before they become problems.
And doctors agree on this.
Clinical and medical groups universally agree on the necessity of monitoring. Now, they don't always agree on every single granular detail of how often or exactly which tests every single time.
Right.
But the principle of ongoing monitoring is undisputed. Nelson does note, generally, the follow-up schedule tends to be a bit more aggressive and frequent in cash-based or specialized clinics, which often prioritize fine-tuning and patient optimization, perhaps compared to some more traditional healthcare settings.
What's a typical follow-up schedule look like?
Generally, you'll have comprehensive baseline tests before you even start therapy. That's crucial. Then, a really important follow-up blood test usually happens at week 6 to 8.
Why 6 to 8 weeks?
That's typically enough time for your levels to stabilize on the initial dose, allowing the doctor to see how you responded and make necessary dose adjustments up or down.
Okay. Then what?
Another follow-up might be done around week 12 or 16, just to confirm things are settling in well. Once your dose is stable and optimized and you're feeling good, monitoring typically shifts to maybe annually, though some doctors might prefer checks every 6 months, especially initially.
What key things are being monitored in those blood tests and exams?
Regular monitoring of testosterone levels is obviously central. How you check depends on the method.
How so?
For injections, Nelson actually suggests it's best practice to check peak testosterone maybe 24-48 hours after an injection to ensure adequate levels are being achieved. Though he notes many doctors mistakenly only check right before the next injection, which only shows the lowest level, the trough, and doesn't give the full picture of the peak or average.
And for gels or creams?
For gels or creams, levels should ideally be checked about 6 to 8 hours after application to capture their peak absorption.
What's the goal level?
The general goal is usually to get total testosterone levels consistently into the upper part of the normal range, maybe above 500, 600 NGDL, or even a bit higher depending on symptoms and free T for optimal benefits.
What else is crucial to monitor besides T levels?
Hematocrit, that proportion of red blood cells in the blood, this is critically important. Most medical groups agree this should be measured every 3-6 months, especially in the first year.
Why so often?
Because, as Nelson notes, highest levels of testosterone often correlates to highest risk of increased red blood cells. Monitoring lets you catch it early and manage it, usually by donating blood or adjusting the dose before it becomes a problem.
Prostate health.
PSA, the prostate-specific antigen, also requires ongoing monitoring. This is usually done with a blood test, sometimes alongside a digital rectal exam, typically annually once stable.
What if PSA increases?
If PSA increases significantly, the usual threshold is more than 1 ng/ml over a 6-month period, then a urology consultation is generally recommended for further investigation.
Bone density.
Bone mineral density is not routinely checked by most doctors unless the patient is older, has known osteopenia, osteoporosis, or has a history of fractures. It changes very slowly, so frequent checks aren't usually necessary.
And cholesterol. Lipids.
Lipids are only mentioned by one major guideline as needing a check at week 6-12. So there's varying emphasis, but checking lipids periodically, maybe annually, is still a good idea for overall cardiovascular health monitoring.
So Nelson's guidance on adjusting dose based on these tests.
His guidance is pragmatic and really patient-focused. He says simply, if blood levels are lower than expected at week 6 or 8, your doctor should increase the dose, get the levels optimized.
And about frequency.
He adds that increasing injection frequency, like going from every 2 weeks to weekly or weekly to twice weekly, helps decrease peaks and valleys. This is crucial for achieving more stable, consistent levels, which usually leads to better results and fewer side effects for you, the patient.
Okay. Now, to kind of wrap up the core of TRT management, Nelson Vergel offers this Powerful set of 10 TRT commandments. These sound really practical advice for the patient themselves.
Yes, they're fantastic. Practical, actionable advice based on his decades of seeing what works and what doesn't, aimed directly at empowering the patient to maximize success and minimize issues.
Let's run through them. Number 1.
His first commandment is, have reasonable expectations. We talked about this. Don't go into TRT expecting it to be a magic cure-all for every single thing in your life. It's powerful, but manage expectations.
Number 2.
Second, emphatically, do not fall prey to testosterone booster scams. As discussed multiple times, they are ineffective, often fraudulent, save your money and frustration.
3.
Third, do not obsess about estradiol without testing it, and crucially with the right test. Use a sensitive estradiol assay specifically designed for male ranges. Standard tests are inaccurate and can lead to unnecessary worry or bad interventions like overusing AIs.
4. Very important one.
Fourth, monitor your hematocrit diligently. He calls it the #1 side effect to watch. Persistently high levels increase blood pressure, can cause headaches, and contribute to potential cardiovascular risks. Manage it proactively through blood donation or dose adjustment.
5. About injections.
Fifth, explore easier ways to inject. Don't stick with painful deep IM if you don't have to. Explore subcutaneous or shallow IM injections with tiny insulin syringes. They make self-administration much less daunting and more accessible.
6.
This sounds important.
Sixth, and this is crucial, never cycle testosterone replacement therapy. Unlike bodybuilders using steroids for cycles, TRT is replacement. Nelson states cycling on and off does more harm than good by continually shutting down and then attempting to restart your natural production. This leads to weeks or months of debilitating low testosterone and hormonal chaos as your body tries to recover each time. Just stay consistent with your prescribed dose.
Okay, 7, tracking. 7th, constantly measure and monitor your blood tests and trends. Be proactive. Don't just rely on the doctor. Use tools like My Health Graphs or the TRT Analyzer app Nelson developed to track your labs and symptoms systematically. Seeing trends helps you and your doctor optimize treatment.
8. About making changes.
8th, do not change more than one variable at a time in your treatment protocol. If you change your dose, your injection frequency, A&D, add a new supplement all at once, you'll have no idea what actually worked or didn't work if you feel better or worse. Change one thing, assess, then change another if needed. Be methodical.
9. Fertility.
9th, protect your fertility and testicles upstream hormones with HCG. If fertility or maintaining testicular size is important to you, human chorionic gonadotropin is an ancillary therapy that mimics LH, keeping the testicles active even while on TRT. Nelson covers HCG in much more detail in his subsequent lectures.
And finally, number 10.
And his 10th commandment is, don't stay behind, meaning stay informed. This field is constantly evolving. New information, new research, new treatment options are emerging all the time. Be an educated patient. Keep learning.
That's a fantastic list. And what's really fascinating here is just the profound emphasis on informed patient self-advocacy, isn't it?
Absolutely. In a field as complex and sometimes controversial as TRT, Nelson's commandments really empower you, the listener, to be an active, informed participant in your own health journey.
Not just passively receiving treatment.
Exactly. This proactive approach, combining personal responsibility and diligent tracking with skilled communicative medical guidance, is truly the path to optimizing your outcomes and confidently navigating the nuances of TRT effectively.
It highlights patient education as just indispensable.
A cornerstone of successful, sustainable treatment.
So while testosterone is obviously the core of the therapy, Nelson Vergel notes that doctors often prescribe other medications or therapies alongside TRT to complement it or maybe address related issues.
That's right. It's often part of a more comprehensive approach. One of the most common ancillary therapies, as we just touched on with the commandments, is HCG.
Human chorionic gonadotropin.
Right. It's primarily used to help maintain testicular size and function, and importantly, preserve fertility for men who desire it while on TRT. It can be used with or without testosterone, depending on the specific goals.
What else is common?
Another medication gaining huge popularity, even beyond TRT clinics, is metformin.
The diabetes drug.
Traditionally an anti-diabetic drug, yes, but it's getting significant attention now for its potential life extension benefits, metabolic improvements, and help with weight management. So it's often prescribed alongside TRT to improve overall metabolic health.
Fertility drugs.
For men still experiencing erectile dysfunction despite optimized T levels, ED drugs like Cialis, tadalafil, or Viagra, sildenafil, are often prescribed. Nelson notes these can frequently be obtained much more cheaply from compounding pharmacies than retail.
Are other anabolic steroids ever used?
In certain very specific medical cases, yes. Oxandrolone, Anavar, and oxymethylone, Anadrol, are anabolic steroids that are FDA approved for particular conditions, like treating severe muscle wasting diseases associated with HIV or cancer. But their use is highly controlled and not typically part of standard TRT.
What about vitamins or nutrients?
Doctors might also prescribe injectable vitamins and nutrients like B12, vitamin D, or specific blends to address diagnosed deficiencies that can impact energy, mood, and overall well-being, complementing the effects of TRT.
Anything else? Newer things?
Beyond that, there are newer growth hormone-releasing hormones or peptides that some patients and specialized doctors are exploring for potential benefits in areas like body composition, recovery, and anti-aging, though these are often considered more experimental. And of course, depending on the individual's overall health, things like blood pressure medications or other targeted pharmaceuticals might be necessary parts of the complete health regimen. It really highlights the comprehensive, multifaceted approach often needed.
Okay, so for listeners who want to learn more, dig deeper after this conversation, Nelson Vergel has dedicated his life to providing resources, right? Where should people start?
Yes, he's incredibly generous with information. For you, the learner, these are invaluable starting points. His primary hub, his cornerstone resource, is ExcelMale.com.
What is ExcelMale?
It's a vibrant, incredibly active online forum site. When Nelson gave this lecture, it had around 18,000 members. It's likely much larger now. It's a truly unique community.
What makes it unique?
You'll find doctors actively participating, answering patient questions. You'll find highly educated, experienced men sharing their practical knowledge and experiences with testosterone and related therapies. There's a wealth of information, regular newsletters, expert interviews, comprehensive reviews of clinics and doctors, free ebooks.
Sounds comprehensive.
It really is. You can dive into detailed discussions about interpreting blood tests, find links to new studies, participate in Q&A sessions with leading experts. The site also covers diverse topics like peptides, hormone replacement therapy in women. It even has Spanish-speaking sections, plus user reviews of specific doctors, clinics, pharmacies, and supplements. It's an unparalleled, patient-driven resource for getting informed.
What about getting affordable blood tests? That can be a barrier.
Absolutely, which is why Nelson developed DiscountedLabs.com. It's his company that provides affordable, direct-to-consumer blood testing in most U.S. states.
How does it work?
You can conveniently order the specific tests you need online without needing a doctor's referral first. You take your order form to the closest partner lab location, like Quest Diagnostics usually. They draw your blood, and you receive your results securely via email, typically within 5 to 7 business days. It gives you direct access to your own health data affordably.
That's powerful. What about tracking progress? He mentioned apps.
Yes. To help you track your personal progress and communicate effectively with your doctor, he developed the TRT Analyzer app. It's free, available on both App Store and Google Play, and had over 8,000 downloads back then.
What does it do?
It allows you to meticulously track daily metrics like energy levels, libido, erectile function, mood. You can plot these variables over time to see trends and then easily print or email the reports directly to your doctor. Super useful when starting treatment or adjusting doses.
And visualizing lab results.
For visualizing your actual blood test results over time, there's myhealthgraphs.com. Nelson mentioned it currently required manual input, but the goal was automatic PDF reading. It provides a powerful visual representation of how your numbers are trending.
And his books.
Nelson's own comprehensive book, Testosterone, A Man's Guide, is available as a free download from ExcelMale.com, providing an even deeper dive into many of the topics we've covered.
Any other recommended reading?
He also highly recommends a book called Natural versus Testosterone Treatments by Lee Meyer. It's a detailed 300-plus page book written by his late friend, Lee Meyer, who was another true pioneer in this field. Nelson actually dedicated his original lecture to Lee.
Nice tribute. Resources for doctors.
For healthcare professionals looking to deepen their knowledge, Nelson created ClinicOptimizer.com, a specialized resource for learning how to safely and effectively treat both men and women with hormones.
And any specific pharmacy recommendations?
Finally, Nelson gives a strong recommendation for Empower Pharmacy. He notes it's a 503B FDA-inspected and regulated compounding pharmacy, highlighting its high quality and adherence to the strict new requirements for sterile compounding. He mentions a close friend as a co-founder. These resources collectively offer a really comprehensive ecosystem for informed self-management and professional development in this dynamic world of hormone health. #tag outro.
So after all that,
Yeah.
what does this really mean for you listening right now? We've covered a huge amount of ground.
We really have, from the absolute basics of testosterone's essential role throughout the entire body.
Right, navigating those complex, sometimes frustrating debates around what low actually means on a lab report.
Exploring the intricate science of how your body makes it, controls it, uses it, the HPTA, the fractions, the conversions.
Delving into those crucial lifestyle factors, sleep, diet, exercise, toxins that you have direct control over.
And then laying out the significant potential benefits of therapy, but also the potential risks and the huge array of treatment options available today.
If we connect all that to the bigger picture, it seems abundantly clear that understanding testosterone isn't just about focusing on a single hormone number.
Not at all. It's really about embracing a much more holistic view of male health.
Highlighting that critical, interconnected interplay.
Exactly. Between your lifestyle choices, your genetic predispositions, and the absolute necessity of getting informed, personalized medical guidance from a knowledgeable practitioner.
Nelson Vergel's decades of insights, distilled here, really underscore the importance of continuous learning too, doesn't it? In a field that's constantly evolving.
Absolutely. And it empowers you to be an active participant in your own well-being, not just a bystander.
You know, the journey to optimizing your health, it often just begins with a single question, right? Or maybe a feeling that something isn't quite right, coupled with a willingness to learn more. And this deep dive, I hope, has shown just how intricate, yet ultimately understandable and manageable, the world of testosterone and male hormonal health can actually be.
It's complex, but not impenetrable.
Exactly. So maybe here's a final thought for you to mull over as we close.
Okay.
If the body's complex hormonal orchestra, as you called it, can be so finely tuned and so profoundly influenced by both our internal biology and our external choices, what other seemingly normal aspects of your well-being, things you might just be accepting, might actually be signaling an opportunity for a deeper dive?
That's a great question to ponder. What else might be open to optimization?
Perhaps there are other unasked questions waiting to unlock further vitality and understanding for you. We certainly hope this deep dive has given you a clearer roadmap and maybe the confidence to explore your own health with greater insight. Thank you for joining us on the deep dive.